So, good evening, everybody. Welcome back to our weekly Fireside chat. This week, we are going to be it's number 148. The topic today is going to be ultrasound, the nephrologist in focus, and Professor Sharad Patel from the United States, who is critical care intensivist, nephrologist, and professor of medicine at Cooper University Hospitals, is going to take us through. It's a pleasure to have you, Professor Patel, and the floor is yours, please. Thank you.
Well, thank you again, everyone, for having me. So again, my name is Dr. Sharad Patel. I'm one of the intensivists and nephrologists. I primarily practice critical care, but I practice still nephrology about 10 to 20% of the time. And my big goal, kind of when I'm educating and I'm is to really connect the things that we didn't seem to think that there were connections, right? So, and one of the big reasons why I wanted to talk about the topic I'm talking about today is that I'll be discussing potential methods to differentiate hypervolemic versus hypovolemic hyponatremia. I like this topic because, as you know, as I'm sure there's some nephrologists in the group, is that it's a spectrum, right? So the things that predispose to hyponatremia, for example, in cardiorenal physiology, as the hyponatremia is getting worse in the cardiorenal, your predisposition to AKI is probably also increasing as well, right? So it's all a spectrum, and I wanted to kind of show how it is a spectrum and how you can potentially use focus to really kind of guide your therapy, right? So one of the first things I want to kind of bring up and mention is this concept of using portal vein pulsatility, or this protocol. I'm not sure of how much of VEXUS protocol has been really disseminated throughout the world, but it's kind of becoming a little bit more of a hotter topic, especially in the POCUS world in the ICU. Because really in the ICU, people are starting to realize how much just having AKI changes the trajectory of just any condition, right? And sepsis, septic shock. When you have sepsis, septic shock, and you add AKI to it, your trajectory, your prognosis, it dramatically worsens, right? So how can we prevent AKI? How can we improve AKI fast, right? And so these are all things that are important. I think the critical care world is starting to wake up to. But within this world, this protocol is called VEXUS protocol, or portal vein pulsatility. It's used as a method to really quantify venous excess, right? So venous congestion is really taking the forefront right now, as far as like things that contribute to cardiorenal physiology and AKI. And so let me kind of like introduce this concept of portal vein pulsatility and VEXUS protocol. So again, this slide's a little cut off, but you can see here on the left, you're talking about the venous excess score, or VEXUS. And what is that? So really the first step when you're looking at this, so let's say you have a patient, you suspect that this patient, let's say it's a 60-year-old patient, they're 10 pounds up, they're having dyspnea, their baseline creatinine's 1, now it's about 2. They have evidence of a low FeNA, low urine sodium, consistent with a pre-renal state, and it's sounding like this person has a CHF exacerbation with this concurrent AKI, and your primary hypothesis at that point might be cardiorenal syndrome. So how do you evaluate this? How do you quantify this, right? And it's helpful to do something like this because it helps you kind of come up with a plan. Do I need to get this patient 2-3 liters negative over the next 24 hours to improve their AKI, or do I have time and should I go slowly, right? So if I'm really extreme, I'm going to have a larger diuretic strategy, right? So like if I'm extremely congested, my GFR is likely quite low, and my diuretic needs and my diuretic dosages are probably going to be required to be higher. And so I will, if I have pretty severe disease, I'll use higher amounts of diuretics to get to my goal. But when you're talking about the VEXUS protocol, so again, if you're talking about venous congestion, so the first step I usually do is we look at the IVC. So the IVC is something that's been around in the POCUS world for quite some time. It's kind of gone by the wayside recently because when we initially started looking at the IVC, right, it was being used as a way to resuscitate a patient. is this patient dry or not? It turns out that's overly simplistic, right? So why is an IVC collapsing, or why is an IVC big and dilated? The things that drive IVC physiology is there's multiple things. There's right atrial pressures, right? So your RV function, LV function. Is there any intrapulmonary hypertension? Is there intra-abdominal hypertension, right? So if your intra-abdominal pressures are 10, 15, you might have a collapsing IVC when your CVP is actually quite high, right? So your negative to thoracic pressures, are you breathing like this, right? So in a COPD exacerbation, if you have a COPD exacerbation, you have these wild negative pressure swings, and you can have a collapsing IVC even though you may have a high CVP, right? But all things being equal, and if you're considering that these other factors are normal, one of the big kind of like drivers of what IVC looks like and what the CVP looks like is your intraluminal volume as well, right? So intraluminal volume or venous congestion is one factor of what you want to consider when you're looking at the IVC. So let's just focus on that part of it. So when you look at an IVC, the cutoff, the value you want to remember is 2 centimeters. So if your IVC is greater than 2 centimeters and it is varying with respiratory variation less than 50%, then that patient likely has a high CVP or a high right atrial pressure. What does that mean to have a high right atrial pressure? When your right atrial pressure is high, and it's likely pathologic, right? So when your right atrial pressure is high, that's telling you that your right ventricle is not able to compensate for whatever reason why there's congestion, right? Is there left-sided disease? Is there pulmonary hypertension? Are you an ARDS now with higher pulmonary vascular resistance? Right? So a lot of factors, or is this primary right ventricular failure, right? So the IVC is just telling you that there's elevation in right atrial pressure. It doesn't tell you what the etiology is, but it helps to kind of go a few steps further, right? A dilated IVC is likely venous congestion. And so if you have concurrent AKI and a dilated IVC, that patient you would likely manage a little differently than what I think the average patient coming in with AKI and the ER would get managed as. So I think on average, when a person comes in with a high creatinine in the ER or on the medicine floors, they usually get fluids, right? So they usually get fluids. But in this situation, if you have a dilated IVC and you have AKI, giving more crystalloid or volume expanding them is likely going to worsen their physiology. It's likely going to worsen their AKI. And what's happening is if your right ventricle is already dilated and you're adding volume, you're basically congesting it more, right? And then that physiology that's causing the venous congestion, that dilated IVC, is going to cause more pressure on the kidneys, and that perfusion pressure, the MAP minus your CVP, is going to drop, right? So your perfusion will diminish as well. You're going to develop renal interstitial edema, right? So the overall, this whole physiology will get worsened. That person you might want to consider diuresing, right? And now for a nephrologist or a cardiologist, on average, when you have AKI, diuresing them to improve their renal function, it's not a foreign concept, right? But I think there's some sort of kind of this cognitive dissonance where if there's a AKI, there's this kind of like block for a lot of physicians to say, okay, I need to remove volume. Usually the concept is the first kind of intervention is to give volume. So this helps prevent that. So once you've established that you have a dilated IVC, the next thing you would look at is the hepatic vein. Now the hepatic vein is exactly where you'll be looking at the IVC. It's going to be dumping into the IVC, and you would basically interrogate this Doppler. Now, I could do a just entire talk on Doppler and how do you interrogate things, but I think this is kind of out of the scope for just an hour long talk. I really want to just focus on concepts today, but I will 100% leave resources for if anyone wants to learn how to do these things, how they can learn a little bit more. So once you're interrogating the hepatic vein, this is what normal looks like. Your systolic is greater than your diastolic. So this is a normal pattern. This tells you that there is likely normal CVP. But as congestion worsens over time, this is the picture you get. The diastolic component gets bigger, and then eventually you'll just have one wave. If you see this picture, where you have just one wave and this systolic flow reversal, meaning you probably have severe tricuspid regurgitation. Blood is going backwards rather than forwards. And so if you see this picture, you probably have pretty severe congestion. Next, you would look at the portal vein. The portal vein is kind of interesting, right? So it's in the liver, and normally it looks like what a vein should look like. You shouldn't have pulsatility. It should have a flat profile, right? But as the liver gets more congested, right? So if you imagine this concept where you have venous congestion, you will eventually get interstitial edema in these organs, the kidney, the liver. And as the kidney or the liver gets swollen, there's a capsule around it. So there's only a limit, there's a limited amount of expansion that the actual kidney or the liver can do. And so that will cause kind of compression of the veins and arterialization of it. And so you'll start getting pulsatility as the liver gets more engorged and gets more swollen. And so as there's more swelling, you'll eventually get to this greater than 50% pulsatility kind of thing. When it gets really severe, it can get biphasic actually. So this is a portal vein, right? And the last one is, this one's the most difficult, right? So what you really need is you need two of these. So you need your IVC and you need at least two of these. And if this is kind of looking like that the IVC is big and two of these are severe, you kind of have your answer. And then the way this grades is your grade 0, grade 1, grade 2, grade 3. Grade 3 is as severe as it gets, and basically all the tests are severe. So I usually stop here because I'm able to get these two quite easily. The renal vein is probably the most difficult. This one, I'm quite experienced doing this. I get this around 70-75% of the time. The portal vein, I can get 90-95% of the time. The hepatic vein, I'll get 100% of the time. But this one is a little bit more difficult. But what we're looking at here is normally, so you'd be looking at this bottom, this gray signal here on the bottom, on the renal vein Doppler. And you see, it's just like a normal vein. It should be a flat profile. But as congestion, interstitial edema worsens in the kidney, you'll start seeing this kind of like biphasic picture, a systolic and a diastolic. And then eventually, as severity worsens, you start getting just a monophasic wave. So this is severe renal venous congestion. And so you see this picture and you see AKI, you need to be diuresing that patient. It just, this patient needs liters and liters and liters off. So you should probably be aggressive with your diuretics at that point. When I see this picture, I will usually use a combo regimen like a Lasix and a Lasix or some thiazide diuretic to optimize, to augment natriuresis, so sodium removal and not just water removal, right? So I'm trying to really, really decongest that patient. So this is kind of like a primer on portal vein pulsatility. Now that we've talked a little bit about what this protocol is, I want to introduce this concept of this kind of a, this isn't it, this it, just with the caveat, this is still in its experimental kind of hypothesis stage. But I think the physiology holds. And in my practice and like the small case series we did, it definitely kind of, it looked like there's something there. So, but this needs to be studied further. So when you have a patient that you're suspecting cardiorenal physiology in, right? So this is kind of the physiology that you're seeing. And this patient's hyponatremic. So you have your low cardiac output, you have your venous congestion. This eventually leads to decreased overall renal perfusion, right? So the driving pressure for perfusion is going to be your MAP minus your CVP. It's more complicated than that, but let's just say for just simplicity, it's MAP minus CVP. When you have this kind of like reduced perfusion, you have increased sympathetic tone. So when you have increased sympathetic tone, you'll have concurrently increased renin, angiotensin, aldosterone. This physiology causes proximal tubular reabsorption of sodium. And so this whole process of where you're already sodium up, you're already volume up, you're already congested, this will only worsen that physiology, right? So you'll retain more sodium. The high renin, angiotensin, aldosterone and this will worsen the overall physiology. This I always found fascinating. I think evolutionarily this is very interesting to me. Was that why is it that this body, why is it that the humans have evolved to have this kind of maladaptive behavior in bad heart failure? And one kind of like hypothesis that I had was that throughout human history, 100,000 years ago or 50,000 years ago, our lifespans weren't as long as they are now, right? We didn't often live to where we're having chronic diseases like heart failure. And so usually things like dysentery and things like that is what led to mortality, right? And so the body's mechanisms are optimized to retain volume. And so if whether it's a weak pump or low volume, the body really can't tell the difference, and the physiology is exactly the same, right? So when you have high RAS, this increased sympathetic tone, you have increased sodium retention. The body seems to think that you're intravascular depleted, you're in the Sahara Desert, you're dry, or you're bleeding out, right? So this is kind of the physiology, and this is what has kind of led me to think that this is the reason why we evolved this way. Um, and this will lead to hypervolemic physiology, right? So this will kind of worsen the hypervolemic physiology. And you'll get hypervolemic hyponatremia, right? So you have increased total intracellular sodium, extracellular sodium. You have diuretic resistance because if you're reabsorbing everything proximally, nothing's being delivered. Less volume is being delivered to the loop, to the distal convoluted tubule. So diuretic resistance will happen, right? And then you'll have impaired dilution capacity. You have decreased distal delivery and when you have decreased distal delivery, your dilutional capacity decreases as well. And then your hyponatremia will worsen overall. And then any free water intake you have on top of that, your sodium is going to drop, right? And so this right here, this equation over here on the right, where you have sodium plus potassium over total body water, your sodium and potassium is increasing, but your total body water is increasing even faster, right? In this kind of a physiology. And that's why your hyponatremia will worsen. So when you catch this earlier enough, when you have your functional pre-renal AKI, this can potentially be reversible. Now, again, this is just speculation in that what I have noticed is when you have this physiology and you check a urine sodium or a FeNA and it's low, that's telling you that there's enough tubules that's still functional to retain this degree of sodium, right? And so that kind of tells you there might be some reversibility here, right? And so when I see this picture, I try to jump on it as fast as possible. And eventually, if you let this physiology keep going, you'll eventually get parenchymal AKI secondary to cardiorenal syndrome, right? So this is kind of like just a flow diagram of what I've been talking about. So when you have hyponatremia and kind of a decision tree, you're obviously talking about breaking it up into volume. Now, this is much harder than it sounds, right? And we all know this. There's plenty of evidence now out there in the literature that pitting edema, a little bit of congestion, the X-ray, that these are not great methods to assess intravascular volume or venous congestion. I truly think you need to go towards ultrasound step to really get a volume status assessment. And whenever I have a hyponatremic patient where I suspect that there may be a cardiorenal syndrome physiology, I'll put an ultrasound probe on them. Now, the caveat to this is that you need to learn when you pick up the probe and you're looking to figure out if there's something more complex or not. If I have a history of someone with coming in with cholera, right? So, and just they're throwing up and they have profuse diarrhea, I'm not ultrasounding them. I don't, the pretest probability of intravascular volume is reduced volume is so high. There's no point. I know this patient's on the left side of here is hypovolemic hyponatremia. I don't need to do an ultrasound. But most patients aren't as simple as that, right? It's just the history sometimes can be ambiguous. So when I'm not sure, I'm trying to make sure that this patient, I'm trying to figure out where they are on the spectrum of hyponatremia. Now, both the thing I'm going to focus on is the hypovolemic and the hypervolemic, because those are the two that I think are actually quite difficult to differentiate. So again, because things like pitting edema and things like that, they're not great methods to assess intravascular volume. But the physiology is exactly the same, like I mentioned before. You have high ADH, you have high RAS on both, and you have low potentially urine sodiums and FeNAs on both. And you let this physiology go on, eventually you're going to get parenchymal AKI. Now, the management is completely different as well, right? So on the left, if you have the hypovolemic, you're giving them crystalloid. On the right, you're diuresing these patients, right? So the management is completely different. That's why it's so important to be able to tell the difference there. Now, I'm going to get a little bit more into some cases, but I really want to kind of discuss the physiology of what's going on here as well. So when you have venous congestion, you eventually start getting renal interstitial edema. And so beyond the RAS, beyond the um, renin-interstitial aldosterone, there are some physical manifestations and pressures happening that's causing this reduced GFR. So when you have renal interstitial edema, the pressures are increasing within, right? And again, so the kidney has this capsule it won't rupture until very, very high pressure. So that pressure is just being maintained in the capsule. And so normally for filtration, so we all know this figure where you have your afferent arteriole, you have Bowman space, you have your glomerular tuft, and then the filtrate, the urine will keep going towards the proximal tubule. Then you have your efferent arteriole on this side. Most filtration is happening with hydrostatic pressure, like the oncotic pressure is not contributing as much. It's usually just hydrostatic around capillary pressure around 35 millimeters of mercury. There's not much pressure here in Bowman space. And so this is driving filtration into Bowman space. Now, if you had renal interstitial edema, this pressure on the outside will rise, the Bowman space pressure will rise as well. And so now this gradient filtration will be reduced as well. So this is another physical kind of mechanism of how your GFR will drop as well, beyond the things that I've already mentioned. And so you want to decompress, you want to decongest this kidney going forward. And again, this is why you see that pulsatility. This is why you see that Doppler change, because these vessels are now just congested and the compliance is decreased. So you'll just change the profile of their venous profile. So let's get into a case, right? So I've talked enough. Let's talk about a case and how you would use this method. So you have a 54-year-old patient, presents to the ER and via EMS, and the patient has PA arrest. The estimated downtime was around 20 minutes. After ROSC is attained, the hypothermia protocol was initiated, and the patient was transferred to the ICU. Initial labs, and again, I apologize for the units. I understand I'm being very American-centric here, so if you've used to different units, I apologize, but I will tell you that these are all abnormal labs, right? So the WBC count is elevated. The sodium was low at 115. The normal range is 135 to 145 milliequivalents per liter. And then the pro-NT-BNP was extremely elevated. So BNP, as a marker of just when you have elevated atrial pressures, this is released as a natriuretic peptide to help cause natriuresis, right? So this was elevated, and this is a sign of heart failure. And the urine sodium was extremely low. It was less than 5 milliequivalents per liter. And the calculated FeNO was quite low. So I take a look again. So just to familiarize yourself with this kind of figure, you look at the IVC, you can look at the portal vein, and you can look at the renal vein Doppler. What I often do is I just look at the IVC first. If there isn't congestion, I'm done. But if there is congestion, I'm moving on to the next step. So, right, you're grade 0, grade 1, grade 2, grade 3. And so in this patient, there was a dilated IVC. So I went on and I go and do the easiest test after that. So either the hepatic vein or the portal vein. And when I looked at the portal vein, this is what it looked like. So the thing I would expect from the portal vein is this flat profile. There should be no pulsatility here. But look at this. There's almost like a biphasic, almost arterial. This looks like an artery. And so that, again, just tells me that the liver is so engorged that there's compression, there's venous compliance reduction. And what they found is when you see this, CVP is one of the better predictors of AKI. So dilated IVC is one of the better predictors of AKI. It's much a better predictor of AKI, a cardiorenal syndrome, than cardiac output is. But VEXUS, when you combine CVP or dilated IVC with these additional grades, it is the best predictor of AKI. So the likelihood ratios increase significantly as far as prediction of AKI and cardiorenal syndrome. And so when you see this and you have AKI, you have an answer. You have extreme venous congestion, so this is a severe abnormality. And so that the hepatic vein was significantly abnormal as well. So this is a grade, when you go back to the grading, this is a grade 3 congestion. So I really need to diurese this patient. So based on the labs and the ultrasound findings, we diagnosed hypervolemic hyponatremia and then likely cardiorenal AKI. So we started diuresis. The patient was getting 60 milligrams of Lasix every Q8 hours with concurrent metolazone 5 mg. So again, the augmentation of that, right? So because what can often happen is when you're diuresing with Lasix at the loop of Henle, the distal convoluted tubule can compensate and reabsorb a lot of that sodium. And so we're getting more free water loss and you become hypernatremic and you're not getting as much decongestion. When you combine Lasix with metolazone, you're blocking at the distal convoluted tubule as well. And now the only thing that's left is the collecting duct. And the collecting duct isn't as suited to reabsorbing sodium at large like amounts. So you'll get a lot more natriuresis rather than free water loss. So the patient is now negative about 3.5 liters over the next 48 hours, and the sodium starts to improve. So from 115 to 131. Now, one thing I think in hindsight, that if I would go back and if I were just kind of just nitpicking this, the combination of the Lasix and the metolazone is probably better for the natriuresis. But if I was primarily just worried about the hyponatremia aspect of it, I would do Lasix monotherapy because I do want more free water. I want free water loss, right? And so reabsorption of that sodium at the distal convoluted tubule allows for more free water loss because you're getting free water out, but not as much sodium. In this, you're getting more natriuresis, you get more decongestion, but the sodium will improve at a slower level. But here, I think I was prioritizing the natriuresis over just the rate of the sodium improvement. But that's kind of just a little bit of a nitpicking this case a little bit. It's not as simple as I'm making it out to be, but that's something to think about as well. So we do a repeat portal vein pulsatility. You see that before it was biphasic. Now that it's still bad. This is not normal. This is not a normal finding, but it's now you're just getting some pulsatility, but it's not going to a biphasic value anymore. So there's improvement. And then we get it. And this patient overall just goes on to have improved renal function, surprisingly had improvement in neurologic status, and then AKI and hyponatremia improved as well. I have another case, but I'll stop there for just any questions or thoughts at this point, and then we can go on and do some more cases as well.
Just one question.
Yeah.
How would you manage your fluid status here when you have this much of congestion? How much would you give over 24 hours?
So what would be my negative balance goal? Is that what the question is?
Yeah.
So when I have severe, I'm shooting for 2-3 liters negative. Like when I'm grade 3, it's hard to overshoot a negative fluid balance because one, they're often diuretic resistant, so it's hard to get that fluid off that quickly anyways. So I'm shooting for 2-3 liters negative. And what I found is that once you actually start decongesting beyond a certain point, they become less diuretic resistant because now that you've initially decongested them 1 liter or 2 liters, at that point, you'll have a little bit less renal interstitial edema. You'll have less renin interstitial aldosterone. You'll get more distal delivery to the loop of Lasix, right? So the whole physiology will get better, and you'll start the diuretic dose requirements may actually go down as well. So, but on the first day, I'm trying to shoot for around 2 to 3 liters negative.
Thank you.
There's a question in the chat box. Sharad. It says, could you repeat the explanation why you had to combine furosemide and metolazone?
Yeah. So if you think about the physiology of just diuretics, right? So when you are using just Lasix, you block at the loop of Henle. So you're blocking at the sodium to chloride potassium pump. The sodium gets blocked there. Now sodium is traveling distally, right? And it goes to the distal convoluted tubule. At the distal convoluted tubule, you can have reabsorption, a significant amount of reabsorption. And so if that sodium is being reabsorbed at the distal convoluted tubule and you're getting less natriuresis out, decongestion is all about sodium removal, right? It's not just water removal, it's sodium removal. And so if you block at the distal convoluted tubule as well, you'll get, for every liter of urine out, you're going to get more sodium excretion than if you were just doing this with Lasix. You'll get less hypernatremia as well because the urine that's coming out with Lasix plus metolazone or any thiazide is going to be more isotonic to blood. Whereas if you're just using Lasix, it's going to be hypotonic to blood. And so isotonic to blood, you'll get less hypernatremia and more natriuresis, more decongestion. Hypotonic to blood, you'll get some decongestion, but you'll get hypernatremia as well. I hope that answered the question.
No, that was quite clear. Thank you so much.
Of course.
We have a few more questions if you don't mind taking them.
Yeah, of course.
Continue.
Of course.
Dr. Amar is one of our colleagues, nephrologist. He used to lead the Fireside chats. He's taken a backseat, parental backseat right now. So he's asking the question, what if we don't have access to urine soluble levels? So this is a challenge in Tanzania, where you don't necessarily get urine electrolyte levels. And obviously, for calculation, you need that. So,
of course.
How do we approach the case then if we're not able to calculate?
I think so. When I think about a case, I'm thinking in terms of probabilities, right? And I'm ordering the tests that shift my probabilities to what my primary diagnosis is. The urine lights are helpful, but they're not absolutely necessary. If I put a probe on and the patient has a dilated IVC and high VEXA score, I'm diuresing no matter what. What the urine lights were really telling me, it tells me about reversibility, right? And it only supports my diagnosis as well, that this is primarily a pre-renal high renin-angiotensin aldosterone state. So it's supportive evidence, but not essential. Really, I think the essential part of this is going to be your history and your ultrasound.
Gotcha. Do the same figures that you put on the picture there with regards to the IVC size and everything, do the same numbers apply for children as well?
For children, I don't want to lead you astray because I don't treat children, and I'm not sure if the same values apply to children as well.
Sorry, Dr. Patel, I'm sorry to butt in.
It's okay.
So I'm a pediatrician, and so that's why I was asking, because I was hoping that we can actually introduce this in our intensive care unit. You know what I mean? But it looks like for children, there may be different values.
There might be different, but they exist, right? I'm not familiar with the values, but I am sure. Yes, I am sure that there's normal values out there that people have kind of have a normal range, and you can probably use the same physiology on children as there is in adults.
Okay, thanks.
Of course. I think there's a question is, how do you interpret the IVC diameter and collapsibility in the background of pre-existing pulmonary hypertension as a marker? That's an excellent question, right? So that, chronicity is an interesting thing, right? So in someone with bad pulmonary hypertension, you're probably going to have a dilated IVC. Now, when you have a dilated IVC, and you have eventually, I would imagine, is that you will initially get renal interstitial edema, but you have lymphatics that kind of reabsorb this fluid, and that interstitial edema eventually can get better. And your lymphatics can actually hypertrophy, and they can actually adapt over time, right? So like kind of this, like, I remember a heart failure specialist when I was in residency was asking me, is that why is it that there are patients out there with ejection fractions of 10%, but they don't always have pulmonary edema? How is this possible, right? Or they have elevated wedge pressures and they don't have pulmonary edema. Well, the answer is that the lymphatics actually, they'll hypertrophy and they'll actually adapt over time. I imagine it's the same thing with pulmonary hypertension, where you can have a dilated IVC and congestion, but the lymphatics have adapted over time, and you may not get as much renal interstitial edema and may not get as much AKI secondary to this. But even this will have a limit, right? So the lymphatics can only do so much. So if you have an exacerbation of what your baseline pulmonary hypertension is, you can have an acute on chronic pulmonary hypertension exacerbation. And if you have a dilated IVC and you have portal vein pulsatility and you have the hepatic vein that's extremely abnormal and you have AKI, you probably need to decongest that patient. It's an acute on chronic component of this pulmonary hypertension. Whereas if at their baseline state, they may have had a dilated IVC, but they may not have had pulmonary pulsatility, portal vein pulsatility, abnormal hepatic veins or renal veins. So I hope that answers your question, but that's an extremely complex question that requires a nuanced answer. And hopefully I gave you enough nuance for that.
Thank you, Sharad. There is another question from Professor Kilonzo from Kilimanjaro. He says that emphasizing on the diagnosis of hypervolemic, he is grateful that you emphasize on that. Is it important to know if it is a true hypoosmolar state?
Oh, a true hypoosmolar.
Yes.
Yes. Yeah, I think that's kind of like that's something that you can just check your serum osm on, right? And so once you've established that, in which uh, pseudo hyponatremia, like with the especially at least the labs that I'm dealing with, that's becoming more and more kind of rare. But yes, ideally by the test, by the like kind of like probably the standard way to do this is you'd want to check a serum osm just to confirm that this is truly a hypoosmolar hyponatremia. But what I'm talking about is once you've actually confirmed that, then you're moving on to your next step, and that this is true hyponatremia.
Got you. Another question is, what if the patient was on inotropes? Would you still use metolazone and furosemide?
100%, right? So if the patient's on inotropes and your hypothesis is that this is biventricular failure, you have to ask yourself, is that all right? The inotropes are your crutch. They're helping contractility. But how can I help the physiology even more? So if you think about the Frank-Starling curve for both the left ventricle and the right ventricle, right? Once you dilated beyond a certain point, your Starling curve eventually, like RV, you can argue is that it initially your Starling curve looks like this, but if it gets too congested, there's actually a downward portion of it. So decongesting with metolazone and furosemide is all working towards the same goal. I would argue that with metolazone and furosemide, if you're on inotropes, after 4, 5, 6, 7 liters negative, your inotrope dosages would probably come down and your requirements of that will be even less. So yes, 100%. If your hypothesis is, your evidence is showing that this is heart failure, cardiorenal syndrome, CHF exacerbation, you'd want to use inotropes, metolazone, and furosemide.
Thank you, Sharad. Maybe last question from Dr. Lloyd. Would there be a difference between acute and chronic long-term fluid retention?
Acute and chronic long-term, yes, and to that question, I would just go back to that same kind of lymphatics argument, right? So if you chronically have pulmonary hypertension, chronic heart failure, your lymphatics will compensate over time. And you may not get, you may have a dilated IVC, but you don't have portal vein pulsatility, you don't have monophasic renal vein, you don't have systolic flow reversal or diastolic predominance on the hepatic vein. And so that patient probably is chronic, and you wouldn't be doing much for them beyond just managing their pulmonary hypertension. But if they have an acute exacerbation of whatever their physiology is, you probably are going to get that pulsatility, and you probably want to diurese that patient as well.
Thank you.
Thank you. We don't have any more questions for now. I think we can continue.
So next case, we have a 95-year-old male, history of past medical history of heart failure, reduced ejection fraction. The patient has history of AFib, hypothyroid, increased work of breathing. The patient's on non-invasive positive pressure ventilation, so he's on BiPAP, and labs were remarkable for low sodium, a sodium of 120, serum creatinine of 1.9, and this patient's baseline was around 1.2 or so. So the patient has AKI as well, and a high pro-BNP. So perform a portal vein pulsatility. So again, you see this is this biphasic picture. What it should look like is completely flat. And so this is markedly. And you can see the IVC up here as well. You see this dilated IVC here. And if I were to measure this, 100%, and I know I have measured it, is when I'm getting to this step, I've already measured the IVC. And this IVC, just eyeballing it's 100% greater than 2 centimeters, and probably much less variation as well. Now, one question I always get is that how does this, when you're on positive pressure or if you're on mechanical ventilation, your right atrial pressure is going to rise because of this positive pressure. How do you interpret this then? My answer to that is that I've heard things like, oh, you can't look at the IVC when you're on positive pressure ventilation, mechanical ventilation. My answer to that is that the kidney doesn't know that you're on positive pressure ventilation, right? There's evidence that BiPAP contributes to hyponatremia. And there's evidence that there's increased predispositions, AKI, being on mechanical ventilation. Now that could be just kind of like the trauma of the air and causing lung kidney crosstalk and cytokine issues and causing AKI that way. But I also think that the positive pressure ventilation causes more venous congestion and contributes to AKI in that method as well. So to that, I would say is that the kidney feels the pressure that it feels, right? Whether it's there's a component of mechanical ventilation or not, it shouldn't really matter. So you can interpret it in that context, but just understand that if you're on 20 of PEEP and you have a dilated IVC, you're likely contributing to AKI as well. And so this patient is on BiPAP, positive pressure ventilation, and they're getting this biphasic picture. So again, grade 3 severe, right? And so based on this, I'm diuresing this patient again. So IV furosemide 80 milligrams, TID, then 5 milligrams of PO metolazone, patient 3.5 liters negative, and had pretty significant improvements in their serum sodium from 120 to 136, and a decrease in their portal vein pulsatility. So this is what a normal portal vein looks like. We were able to normalize it. And the IVC is still congested. You can see it's kind of still big and congested, but the pulsatility is normal. So my hypothesis here is that you've probably decongested them. Now you may be wondering, why do I keep looking at the portal vein when I'm trying to figure out what's going on with the kidney? So there's a very strong correlation between portal vein pulsatility and renal vein abnormalities and renal venous abnormalities as well. And so I'm basically doing the tests that I get more success with more often than and extrapolating to something that it correlates with. So in the renal venous, so the liver's congested, the kidney is likely congested as well. And so this is kind of like a flow chart that I've created. So again, if you have someone with hyponatremia, the urine lights again are not essential, right? They're suggestive. When I check a urine light and they have hyponatremia, all that really tells me is that I'm less likely to be looking at the middle, the euvolemic type of the ADH abnormality issue, the inappropriate ADH abnormality issue. I'm looking at some sort of pre-renal picture. It's either hypovolemic or hypervolemic. So it kind of brings me to this decision tree. But really not necessary. You can just put the probe on, and if the patient has any extreme signs of hypo or hypervolemic, you can go on and kind of manage the patient that way. But what I would imagine is that if you do the portal vein, you look at the IVC, if the patient's pulsatile, diurese them and their sodium will improve. If the patient's non-pulsatile, you probably want to give them a little bit of crystalloid and their sodium is probably going to be improved as well. And so both sides, you're shutting down ADH by improving the underlying pathology or the mechanism there. Again, this is kind of like another kind of abnormal example of a portal vein and how do you calculate portal vein pulsatility. So you look at your Vmax and your Vmin. Essentially what it is Vmax minus your Vmin over your Vmax, and that's your pulsatility index or percentage. Anything greater than 50% is going to be abnormal. This is almost biphasic, so this is like greater than 100% pulsatility. So you know that there's severe congestion here. It's really kind of like, in conclusion, like you're looking at hypovolemic, you're trying to figure out if there's hypovolemic, hypervolemic hyponatremia. They're physiologically the same thing. And again, I may have kind of digressed before by giving some sort of like evolutionary thought process of why this is the case. But that's my thought, is that we're in a new era where humans are living till 70, 80, 90 years old. And our organs have, for the first time, are allowed to develop chronic diseases. And I guess that's the success of medicine, right? It's the success of medicine that we've gotten here, but now we're dealing with new problems. And the body has certain mechanisms for survival that worked when we were on the savannas and running from lions and things like that, where the primary problems and death were just things like that. There's dysentery and just trauma or bleeding and things like that. And we evolved very well to deal with this, but we may not have evolved as well to deal with things like chronic pump failure. But it's the same physiology, but you have to manage it differently. I focus on the vexus, but the portal vein specifically because it's the easiest one to do. It provides reproducible method to gauge kind of therapeutics, and I'll follow this over time as well to decide when I need to kind of reverse this. This is kind of interesting too, because when I'm on nephrology, so on the nephrology service, I actually keep a log of something. And so this question of diurese or not, that question is probably 25% of the number of the consults, right? Is this patient over diuresed? Do they need more diuresis? When the initial hypothesis was cardiorenal syndrome and the creatinine is rising. So one thing you have to remember is when the creatinine is a reflection of what happened 48 to 72 hours ago. And so if the creatinine is rising, the patient that came in yesterday, that we just may not, and you give them Lasix, but we haven't really gotten them negative. The physiology just may not have been corrected and the creatinine is still rising. And so what I try to do is I go and I look and I kind of get an idea of what the primary team's bias is. Is this patient over? Most often it's they think they're over diuresed. But what I found at least 75% of the time, and I keep a log of this, is that it's the ultrasound findings, my evidence is opposite of what the bias was, which is over diuresis. It's actually, we haven't really even started diuresing the patient enough, and most of the time when you actually restart the diuretics again, because again, when the creatinine rises, one of the first interventions is to stop the Lasix. It's kind of a chronic, it's just a constant thing that I'm fighting with. But most of the time, based on my findings and based on what I'm looking at, we just haven't diuresed enough.
Thank you, Sharad, for this presentation. I think my appetite for learning more has actually been triggered, and I want to know more on how to do this. So I think you've just kind of give us an appetizer. I think we probably need to have a proper session with you. Maybe if I can just kind of break the ice here. Siten has told me that you're going to be coming in September for the critical care workshop. So
Will be.
yeah, so I think I'm kind of jumping the gun here, but we're looking forward to having you in Dar es Salaam. And yeah, I'll make myself available for that workshop because I'm very keen in learning how to do focus in kidney patients.
I'm looking forward to it.
So maybe if I can just ask a couple of questions while we're waiting for the rest of the participants to ask questions. My first question is, do you need a specific device with a specific quality, or can these, newer handheld devices, the portable devices that I think connect via Bluetooth, can you use those, or do you need a proper high-end ultrasound to actually pick up these tracings that you are showing? And then my second question is, how do you come around, say, confounders like obstructions, so something like, Budd-Chiari or some sort of obstructive picture, in the inferior vena cava, or severe pulmonary hypertension? How do you kind of remove those as biases to the pictures that you've seen? Thanks.
Great. No, great questions. Thank you. So the first one, as far as like the device, when you're doing a full cardiac echo, the better the device, the better. But for IVC, you don't need that like advanced of a device, and portable devices are usually good enough. Now, the caveat to this is that the device needs to have Doppler if you want to be able to do the other things like the portal vein, the hepatic vein, and the renal vein. So Doppler is necessary. But all the newer kind of portable devices, they're starting to add Doppler. And so I think in the next 5 years, every portable device will have some Doppler features as well. And so that's going to, but yes, a portable device going forward, I think will be enough to be able to do these studies. As far as like confounders, that should always be in your mind, right? So one confounder is like a cirrhotic. When you have a scarred down liver, that patient's going to have some pulsatility. So if I have someone who's a cirrhotic, I'm interpreting these with a grain of salt. I will be focusing more on the renal vein in than I would be the portal vein in that situation. And there's no reason if they're cirrhotic why their IVC should be dilated as well. So again, I use a method called Bayesian statistics. Basically, it's just I'm changing probabilities of what my primary hypothesis is. And so if I have someone with a dilated IVC and a portal vein pulsatility, that portal vein pulsatility is going to have lower weight as far as proving cardiorenal syndrome than the renal vein. The renal vein strength would go up more for me. And so the renal veins pulsatile, I'm done. I don't even need to look at the portal vein. And so as far as Budd-Chiari, right? So the Budd-Chiari, I would have to keep in mind what an incidence of Budd-Chiari would be. Now, if someone who's on oral contraceptives has malignancy and known clots in the past, my probability of Budd-Chiari is higher than if someone who's coming in with no prior clots, no cancer history, new heart failure. So that patient's probability of Budd-Chiari is going to be a lot lower, right? So I'm weighing kind of like the probabilities. And so if the probability of Budd-Chiari is low, I'm not really thinking about it. But if the probability of Budd-Chiari is at least intermediate, I'm going to do a actual Doppler, a formal Doppler of all the hepatic vessels looking for actual clots and things like that.
Thank you very much, Sharad. That was quite enlightening. I see there are no more questions. Maybe I can just add one more. So normally when there's a rule of thumb that I usually teach my fellows and my juniors, that when you're diuresing a patient, be it for heart failure or for any other volume overloaded state, you need to weigh the patient so that you can see what the weight loss is on a daily basis. And ideally, you shouldn't exceed more than 0.5 of kg or 500 milligrams per day, because that is safe diuresis. Anything further than that, you may cause hypovolemia and have a pre-renal AKI. Do we follow the same rule in a patient that you kind of pick up with severe, say, congestion? Right, yes, you want to get rid of the fluid, but how soon or how fast can you get rid of it? Given the fact that the patient already has an AKI picture.
Yeah, no, that's a great point. Now, I think just the one caveat to that I would say is that if the AKI is purely venous congestion, you have nothing else, your rate can probably be a little faster. Now, the weight, I don't have a weight rule, but I do say is that from the pediatric literature, your maximal refilling rate from the interstitial space into the vessels is around 300 to 400 cc's per hour. So if you're exceeding urine output of 300 cc's an hour, your vascular refilling is slower than your urine output. And therefore, there's periods of hypotension and probably some renal ischemia. And so I try not to exceed 300 cc's per hour of urine output in that situation. And the same with ultrafiltration, is that oftentimes these patients will be diuretic resistant as well. So I'm going to be putting them on dialysis and doing ultrafiltration and scuff and things like that. I rarely go above 300 unless I see that some people are so congested and their RV is so bad. I've done 400, 500 an hour and their hemodynamics only improve and their creatinine and they start making urine because you've decongested them enough that the RAS goes down and you can actually getting more distal delivery of urinary flow. So I'm sorry, Dr. Wazir, I wish I can give a straight answer, but my colleagues and my friends always tell me I always add more complexity to the answer, and I make people more. The goal is that I just want to make sure that and get the point across. This is so nuanced, right? This is all so nuanced, and it's always context dependent. But I think 300 is a cc's per hour is a pretty good rule that you probably shouldn't exceed per any your risk of AKI will increase if your urine output's increasing beyond that.
Thank you so much, Sharad. I'm not sure if any of the panelists have any questions. I see the audience are quiet. I would like to bring this session to a close. Thank you very much, Dr. Patel, for your enlightening talk. As I said, at least for me personally, it has whet my appetite to learn more about POCUS. And I'm looking forward to going through that workshop with you later this year. Yeah, thank you very much again for getting your time for us. And I'll leave Dr. Lloyd to have the closing remarks, please. Thank you so much.
Thank you so much, Sharad. It's wonderful. I mean, it's a concept that you've really taught us, and a lot that really can be done at the bedside, and devices that would have Doppler. That is very interesting, and I'm sure now the younger generation would actually pick it up, and
100%.
and it'll be a lot of change, especially bedside. And if you have a Doppler bedside, a lot of change that comes on, and not even sometimes not. I mean, may not have sodiums readily available. So doing this and going into the hepatic and going into the renal if possible, yeah, it'll be great. Thank you for coming into the workshop as well. It'll make a lot of difference here coming down. And thanks for the time into Africa. Thank you very, very much. And it was a short notice, and it was like a week before that when I asked me about it. Really came on. We like to have you more often whenever you can do it. It'll be lovely for you to come in. Thank you so much, Sharad. Thank you very, very much. Great.
Have a good one. Thank you.